Hello, thanks to our viewers for joining us, and thanks to you, Dr. Blair, for speaking with Contagion. I'll start by asking a bit about your background in infectious diseases, and we'll just take things from there.
Great, thanks. Yeah, appreciate you reaching out. So I'm recently trained infectious diseases physician at, at Johns Hopkins. I have a couple of hats that I wear. I'm also at Uniform Services University in the Department of Pathology, and then also with a sepsis research group at Henry Jackson. But really, the only hat I've been wearing for the past 3 or 4 months has been that of COVID research and patient care. So it's it's been kind of a thing it's been on my mind pretty nonstop since at least in January.
Understandably so. I mean, even just here, the way watching this kind of unfold in slow motion. I mean, I remember writing my first article about it, and China investigates small cluster of pneumonia of unknown etiology, but having that sense that this was something bigger and stuff. So definitely, it's been months of COVID.
Yeah, and it's I think people say, like, even if they're not in healthcare, that time has a new sense right now. It's you lose your weekends. You're talking to people for 12 hours a day, and it's hard to predict what needs to be done and what the next day is going to be like. But also, I think there's that sense of just having like a Groundhog Day feeling, where every day you're pushing to try to make things better, but every day you wake up to the news and it seems like it's only getting worse. Although I think this week that feeling may hopefully change a little bit.
So on that note, how has this changed your day to day as somebody in ID? Your kind of
Sure, yeah.
everyday experience and what your interactions with patients are.
Sure, yeah. So I'm primarily a research physician, so I spend most of my time during the year doing research. So it's been a little bit of changing how I do research, but also changing clinical care. I am on clinical service right now for doing infectious diseases consults. It's it has changed a lot for a lot of people, and I think there's been a different roles that are being filled by infectious diseases physicians because there's so much to do. So I think that what I'm doing is not necessarily what another infectious disease doctor is doing. But kind of to get to the basics, so typically when somebody calls infectious diseases and asks a question, we look at the chart and we go see the patient, and then we talk to the team and write a note, and kind of do that throughout the day. And that's just kind of that's in a nutshell. Now there's a lot more dynamic changes. It's hard to predict some of the workflow. The division at Hopkins, I think, has done a really good job preparing to make sure that we're well equipped to answer the large number of questions related to patients with COVID or under investigation for COVID. One, I think the most tangible change is that of thinking about infection control and to a much higher degree and putting it into our workflow. I mean, we're used to having to put on gowns and gloves and oftentimes masks for the majority, if not the majority of patients, a large number of patients. But this is entirely different than what we're used to doing. There's certain areas of the hospital where I think the setup is more similar to what I am more acquainted with in places I visited in sub-Saharan Africa, where they have a donning and doffing station. They have a safety officer that makes sure that you do everything appropriately. You have to change into scrubs that are either washed or thrown away before you go into these areas. While we do have to wear masks throughout the day for anything we do, then if we go into these certain areas where there are patients with COVID-19 or are under investigation for that, then we do have to put on the gown, the double gloves, the N95 or the PAPR and the face shield. And so I think that there's that extra time factor, but also thinking about what we can do both from a systems level, but also an individual level, so that you minimize the risk to other patients that don't have COVID-19. So just for example, one thing you might do is see all the other patients that don't have COVID-19 first, and then at the end of the day, see those with COVID-19. But of course, you have to consider the acuity of illness too, and also want to prioritize those that have more acute illness.
That's right. Yeah, that makes a lot of sense. So looking into your background a bit, you have some experience in Ebola, and could you detail that and let us know how it has informed your reactions and responses to what's going on now?
Sure, yeah. So most of my experience in Ebola has been that with research. So both in lab studies, but in observational studies in East Africa and also West Africa, and in areas where there is a lot of biodiversity and population density, and a lot of times poor health infrastructure, and so that those areas often can unfortunately lend itself to the development of viral hemorrhagic fever outbreaks. When I was a resident, there was the 2013 to 2016 Ebola outbreak, which basically spanned my entire residency. And I think due to the policies, which I think was not unique to where I did residency, it was expected that house officers did not go to West Africa for obvious infection control reasons and making sure that there are adequate personnel. But I do think it's challenging for trainees to not be able to contribute if they really do want to contribute, when I think a lot of times that is what that's the sort of thing that has motivated people to go into this line of work. It's kind of just selflessness when disaster strikes. So I think that's one thing that I've been thinking about, is that it might be challenging for some trainees who, on one hand, for the trainees that are being thrown out there and into the midst of the pandemic, just imagining what that's through. But then the other hand, those that are kind of stuck at home or isolated or quarantined, I imagine it's also challenging for them who feel like they really want to help. And I think there's just been this sense of community, and also just everyone really feeling that the current state of things is unacceptable, and everyone trying to find one way or another a way for them to help. The other thing I think that in relation to the research work I've done with Ebola that I've been thinking about is how a lot of people did not expect this type of Ebola setup to occur in United States hospitals to this degree. I mean, it is not the same level of PPE or personal protective equipment, but I think one of the takeaway points is that while emerging infectious diseases may occur in isolated outbreaks, that I think people need to realize that, or I think people have started to realize, which has been Unfortunately, it took a while to realize until it was a little bit too late that the virus knows no boundaries, and particularly with the extent of globalization and transportation and increased population densities in the world. That I think the unfortunate reality is that these have been continuing to increase over the past decade, and that I think they will continue to occur in the future. And this, I think, the outbreak was obviously unprecedented in a lot of ways, at least within the past 100 years. And so I think in most of our lifetimes, we've not experienced this before. And I think now that it's happened in the vast majority of countries in the world, I think we are, it's going to, I think, change our lives in policies and the way we think about emerging infectious diseases in a way that we could have never anticipated.